I think we will proceed on since Catherine Schmitz is not momentarily here, but hopefully coming shortly. And we'll flip to the video presentation from Yana Najjar, our faculty, who is talking in the talk that follows that on treatment of the situation where PD-1 doesn't work. PD-1 refractory disease is probably the major gap in the field right now. And so it's a pleasure to have Yana talking, even though she was out of town and she pre-recorded this. So Keith, we'll turn it to you to boot Yana's talk up, and here it is.
Hi, everybody. My name is Yana Najjar. I'm one of the medical oncologists here at the UPMC Hillman Cancer Center, also specialized in melanoma, like so many of my partners from whom you've been hearing this morning. And it's my pleasure to be speaking to you today about updates on immune checkpoint blockade resistant melanoma. These are my disclosures, which should not impact on our discussion. So I'd like to first of all try and contextualize this conversation. Historically speaking, the overall survival for a patient with metastatic melanoma in the pre-immunotherapy era was under 6 months, and over decades and decades, very little headway was made. Very happily, more recently, you can see here data from Checkmate 067, which was the pivotal clinical trial combining two kinds of immunotherapy, ipilimumab and nivolumab, and you can appreciate that at 6.5 years, 49% of patients are alive. So how did we get from A to B? It's really by changing the entire treatment paradigm. From antiquity, really, up until relatively recently, the paradigm was to directly target the tumor with surgery, radiation, and or chemotherapy. Currently, however, the way we approach diseases, oncologically speaking, and melanoma in particular, are by targeting the immune system and allowing it to do what it's supposed to do in the first place, which is kill cancer cells. So immune checkpoint blockade, I'm sure you can appreciate, has completely changed the name of the game in oncology, and first and foremost in melanoma. And what I mean by that is that all of the immune checkpoint agents were first tested and then first approved in melanoma, and since then have been tested in so many other disease indications. So the way we think about treating patients with advanced melanoma in 2023 is, generally speaking, almost always to start with immunotherapy. And that's because of the results of the pivotal DREAM-seq trial. And this question asked us, the question we asked here was, if a patient has a BRAF mutation, which approximately half of patients with melanoma do, is it better to start with upfront immunotherapy or targeted therapy? And the answer was an unequivocal finding, showing us that overall survival is superior if you start with immunotherapy, regardless of BRAF mutation status. Meaning, if a patient has a BRAF mutation, we really do prefer to start with immunotherapy rather than targeted therapy upfront. 2-year overall survival when patients were treated first with immunotherapy was 71.8% at 2 years versus 51.5% at 2 years when we started with targeted therapy. And so the long and the short of it here, I don't want us to get lost in the weeds, but what I hope you can appreciate is that there's actually a 20.3 difference in overall survival when you start with immunotherapy. Now, of course, I said half of patients have a BRAF mutation, the other half don't. But regardless, this has taught us that upfront immunotherapy is superior. And so when we think about what agents to utilize in this day and age, the decision we're really making is, are we going to treat the patient with the oldest combination, if you will, which is ipilimumab and nivolumab? Are we going to treat them with the new kid on the block, which is relatlimab and nivolumab? Or are we going to treat with anti-PD-1 immunotherapy, monotherapy, meaning one drug on its own, such as pembrolizumab or nivolumab? And there's a lot of nuance that goes into that decision, and certainly I think it's a topic for another day. But the point I would like to make is that there are now several options in the upfront setting. And most recently, our first third-generation checkpoint was approved. That's relatlimab, which targets LAG-3, another negative immune checkpoint that also sits on T cells, similar to PD-1 and CTLA-4, which are the targets of the other immunotherapy agents. And this combination was approved on the basis of doubling progression-free survival, meaning how long patients went before the scans showed progression of disease compared to nivolumab monotherapy on its own. Now, I mentioned earlier Checkmate 067, and the reason you'll hear us quote this so often is in a lot of institutions, it's one of the agents that's most frequently utilized upfront, or one of the combinations rather. We have pretty mature survival data now at 78 months. And we think one of the reasons that this works so well is that each of these drugs is hitting a non-redundant pathway in what we think of as the cancer immunity cycle. So you're not hitting the same target twice. The two punches that you're handing to the cancer are completely separate. And we think this is what makes it so effective. Now, of course, the problem is that even though we've made enormous strides and the overall survival is now 49% at 78 months, which really would have been unimaginable even a decade ago, the fact of the matter remains that we've lost 51% of our patients by this time point. The other thing I would say is of these 49%, the majority do not have recurrent disease, but certainly some do. And so there's really a very important and as yet unmet need for standard of care second line plus therapy. And when I say standard of care, I mean something that we can mostly all agree works so well that it can be given to patients outside of the context of clinical trial. So patients who develop primary resistance, meaning the immunotherapy never worked, or patients who develop secondary resistance, meaning it's worked for some time and then stopped working, are still a very underserved population outside the context of clinical trial, as there is no standard therapy. Now, if a patient has a BRAF mutation, we may opt to treat with BRAF targeted therapy at this point. But again, as you may have heard, or as you may know, the amount of time that you get before patients progress on BRAF MEK targeted therapy is not ideal. And what I mean by that is the most recent iteration we have of these drugs will yield progression and at 14.9 months in about half of patients. So how can we extend the benefits of immunotherapy to more patients? This is really something my partners and I spend all of our time thinking about, and certainly not just us, but the field in general. And there are many different approaches that are being evaluated, such as different ways of stimulating the innate immune system. We have multiple clinical trials in this space at our institution. Third generation targets LAG-3 or relatlimab was just recently approved. There are others under heavy investigation. And then perhaps volume-wise, the most of what you'll see in clinical trials is synergistic combinations. So immunotherapy with a different agent, such as targeted therapies, cytokines, vaccines, or combining one of the third generation checkpoints with one of the innate stimulatory strategies, and so on. And to do this, you really need to take a holistic approach, if you will, to understanding what the disease states, not just thinking about the tumor itself, but also thinking about the environment of the tumor, the physical being of the tumor, all of the different cells and pathways that are implicated there. The host themselves, including their gut microbiome, and this is really something that Dr. Devar has led the charge with, as you'll be hearing about. And increasingly trying to get readouts from the peripheral blood, which is appealing because you can sample the peripheral blood with a peripheral stick rather than getting repeated tumor biopsies. So really trying to look at all of this together and understand how we can overcome immunotherapy resistance, which I would argue is the biggest question facing our field. So early hints that the gut microbiome was really heavily implicated in modulating responses to immunotherapy. When you say anti-PD-1 immunotherapy, what we mean by that is pembrolizumab or nivolumab. And this was really very elegant work showing that the gut microbiome was fundamentally different in mice that were responding versus not responding. And this carried over as well into human studies with higher alpha diversity, meaning more different kinds of bugs, essentially, in the gut of patients who responded to immunotherapy versus who did not. And this had implications on how long patients survived without progression of their disease. And this work was led by Jen Wargo out of MD Anderson. And this finding was really taken one step further by Dr. Davar. And I won't get into too much detail because you're going to hear about this a lot more in a dedicated session to this topic later today. But essentially, what he did was to ask, can we salvage patients who have ceased to respond to immunotherapy by giving stool from a complete responder, a sustained complete responder, to a patient who is not responding? And the idea there, of course, is that you're giving the good microbiome to a patient whose microbiome has just not been permissive to immunotherapy. And in fact, what Dr. Davar showed in this very elegant work was that you could, in fact, salvage a proportion of patients who had stopped responding to immunotherapy. Patients who had clearly gone on to progress on immunotherapy when they received a single fecal transplant and a one-time colonoscopy and continued on their immunotherapy went on to have responses. As you can see here in the blue, a number of patients had stable disease, that's a steady line, and a number of patients had partial response, meaning at least 30% reduction in their tumor burden. Those are the three patients you can see lower down on the spider plot. And in work that I'm sure Dr. Davar will further discuss, they also showed that there was modulation of the host immune system, meaning fundamental changes in how the immune system interacted with the cancer and with immunotherapy post-fecal transplant. Now, one area that we've been very interested in and we've been working on for many years and continue to work on is understanding how the metabolism of the tumor cell itself impacts responses to immunotherapy. And this is work that I've done in conjunction with the Delgoff lab. And what we've done is sample patients' tumors over time, either at baseline or over progression. We have done this for many, many patients over the past several years. And we have shown that tumor cells really behave very, very differently across different patients, which is no surprise. This is very, very well known. But here I'm looking very specifically at the way they make energy for themselves, be it through oxygen or through glucose utilization. And fundamentally, what we showed is that tumor cells, melanoma tumor cells that have high oxidative metabolism actually are associated with this very hostile tumor microenvironment, meaning the immune cells there just aren't working as well as they ought to be. And they have what we call an exhausted, dysfunctional phenotype, meaning they're not doing their job. They're unable to. We also found that this high oxidative phosphorylation phenotype of tumor cells is associated with hypoxia or low oxygen throughout the tumor. And as a clinician, of course, it really is a big so what until we show that this has implications on treatment outcomes. And we did find that patients' survival really appeared to be intimately tied with their tumor cell metabolism. And this is their overall survival, progression-free survival, and how long they responded to immunotherapy. So we took this one step farther to say, well, what's happening to tumor cells at progression? So I showed you in the earlier slide in the upper left over here, I'm not sure if you can see my cursor, but in the upper left that there's actually a lot of heterogeneity between patient tumors at baseline. However, here in the figure on the right, the red dots you can appreciate compared to the black, when patients go on to progress on immunotherapy, they are more often than not associated with this high OXPHOS phenotype. So we think that there's essentially a selective pressure that is one of the many, many ways that melanoma tumor cells escape immunotherapy. We think that melanoma tumor cells with this high oxidative metabolism are able to clonally expand and escape the effects of immunotherapy. And this has really been shown multiple times in our patient sample. So we started to think that perhaps mitigating or addressing hypoxia in the tumor microenvironment might be a way to salvage patients who have ceased to respond to anti-PD-1 immunotherapy. And this is a clinical trial that is almost done enrolling at our institution. And it's a phase 2 trial of nivolumab, which is, of course, anti-PD-1 immunotherapy, and axitinib, which is a modulator of hypoxia. It's a VEGF receptor inhibitor. And the reason we combine this is exactly I had previously showed you. We think that if we can decrease hypoxia in the tumor microenvironment, we may be able to salvage patients who have ceased to respond. And the data, we generally try not to share data before a trial has completed enrollment. But what I will say is we have seen some patients with partial responses across different subtypes of melanoma, including mucosal and acral, which are notoriously difficult to treat. And also many patients who have stable disease, meaning they had previously been progressing and now they're holding steady. So certainly, I look forward to discussing those data with you when the trial finishes enrollment. So what else is coming down the pike? I mentioned our nivolumab axitinib. There are many different strategies looking at hypoxia in the tumor microenvironment, but also we're learning how to rethink older drugs, if you will, such as interferon, high-dose IL-2, and various cytokines or small molecules in the blood. And this is one of Doctor's many claims to fame as the developer of high-dose interferon, which for decades and decades was really all that we had in the adjuvant setting. And so this was one of our earliest signals that interferons are of clinical significance in melanoma. And then high-dose IL-2, which was approved for renal cell in 91 and then melanoma in 98. And this modality is associated with small numbers of patients with complete response, but these are very durable. But the toxicity of high-dose IL-2 has really limited its utilization. And so there are multiple next generation or engineered IL-2s that are being studied. And the whole idea here, and this is being done in many different ways, is to maximize the efficacy and minimize the toxicity by basically engineering the molecule to bind to the receptors you wanted to on the good cells and not bind the receptors on the bad cells. And the thinking here is that you will be able to significantly minimize toxicity, which is really the rate limiting step with these agents. And you can see here a figure which I think does a good job of outlining that there are multiple ongoing trials of various cytokine combinations, including IL-2, interferons, IL-12. Some of these are injected directly into the tumor, and so on and so on. So really a huge field. One of these is nemvaleukin alpha, which I include here because we have seen some recent data, and the molecule is engineered in order to bind to the good receptors. And what I mean by that is the intermediate affinity receptors on the immune cells. And it's really not binding to the higher affinity receptors on cells like T regulatory cells. And we think that when they bind to the Treg, that's really where you run into all of the toxicity. So you're getting the good without the bad, in theory. And this has shown increased numbers of intratumoral and peripheral blood effector cells. And perhaps most importantly, durable anti-tumor activity. And I think this is particularly interesting because there have been also responses in mucosal melanoma, again, a subtype we often think about as harder to treat. And so there's now a global study enrolling both mucosal and cutaneous melanoma, which I think as an investigator is refreshing because oftentimes you do not see these subtypes included together. Mucosal is not as responsive, and so it's often not included. So I was glad to see that both are enrolling here. And there are 2 cohorts and again, a clinical readouts pending here. But this is the Artistry 6 trial, and I think it's an important trial in this space. Oncolytic viruses, this is not a new concept. As a historical footnote, it's fascinating. People were injecting different bacteria, different viruses to try and get the host immune response to deal with that. But at the same time, you would also have shrinkage of tumors sometimes. So TVEC is approved by the FDA for unresectable melanoma on the basis of an overall response rate of 26%. And there are many agents now being evaluated to try and do better than this, if you will. One of these is a trial being led out of Pittsburgh. This is Luminos 102. It's a poliovirus clinical trial that's enrolling at multiple sites throughout the country in combination with anti-PD-1 immunotherapy in one of the arms. And I will show you, if I can have your attention on the lowest part of the figure, you can see that we have seen some responses in injected and non-injected lesions, which is really important because that's one of the issues really with TVAC. You don't often see responses in non-injected sites, which has limited its utility. So this is a trial, again, that is enrolling without mature data yet. The IGNITE trial, we very recently saw data from. This is RP1, a herpes virus that is being developed by Replimune. And the IGNITE trial has multiple different cohorts. And again, I don't want us to get lost in the weeds, but what I want to draw your attention to is that the patients here had progressed on anti-PD-1, either in the adjuvant or in the metastatic setting. And if you put all these cohorts together, you can appreciate that 36% of patients had an objective response, meaning eradication of their tumor or significant shrinkage of their tumor, with a disease control rate approaching 50%. I think this is particularly important because it appears to be pretty well tolerated. And of course, we'll have to see where this goes moving forward. But I think this is another interesting agent when we think about what's next for immunotherapy-resistant melanoma. This is also injected into the tumor, just like the oncolytic viruses I had shown you previously. The timing and duration of prior anti-PD-1 therapy for patients who are responding, I think, is also interesting because you can see that most patients who had responded to the RP1 agent had previously progressed relatively quickly through immunotherapy. So that's a nice salvage option because we know patients who progress quickly on immunotherapy, we really worry about those folks because, you know, with no standard second of line, the question becomes, if the disease is moving so quickly, what can I do? So when you see something that works in a patient who's previously rapidly progressed, that's very reassuring to us as clinicians. And very, very important as well is not just to consider whether or not patients are responding, but how long are they responding for? And that's what we mean when we say a durable response. And you can see here 85% of responders have an ongoing response. Again, you can see here, very important, as I had shown you previously, for the other agent, here too, you can see there are responses in uninjected lesions. So up here, this is the liver, there's a metastasis at the center, and you can see over time, this lesion is shrinking. You want to be looking down that column. And then across each of the rows are different metastases that if you look down, you can see are shrinking with repeated injections. Now, if you were to ask us, what do we think is going to be the most immediately approved agent? I think most of us would venture an educated guess of adoptive cell therapy, although, of course, this is still under review and we really don't know. But I think the data bears discussion because it's good data. And so when I say adoptive cell therapy, what we mean by that is removing the tumor from a patient, separating out the immune cells, growing them by the billions in the lab. The patient comes into the hospital, gets chemotherapy for about a week, and then we give them back their own immune cells. And then we start to give them high-dose interleukin-2, up to 6 doses, to really try and boost that immune response. It's a pretty involved modality, but on the other hand, it's a one-and-done modality, if you will. And so this is the C14401 study that was led by Iovance. And the point I want to make here is that they have various cohorts, but these are PD-1 refractory patients. I also put this little box on the side as a historical footnote because you can see that what we're doing in 2022 really very, very closely mirrors what was being done in the mouse models by Steve Rosenberg in the 80s at the NCI, and when this modality started to be developed. So looking here at the baseline disease characteristics, I want to draw your attention to a few things, which is that both cutaneous and mucosal melanoma were permitted. Patients did have, they did include patients who had metastases in the liver or the brain. We think of these as distinct populations because they're harder to treat. A significant number of patients had an elevated LDH, also an important prognostic marker, and the number of prior therapies on average, or the median number of prior therapies, was 3. That's very important because it tells you that this is a patient whose disease has progressed on many different agents. And so when you see responses here, it's especially meaningful. And the objective response rate is when you combine 2 of their cohorts, which are treated the same way and which have very similar inclusion, very similar baseline demographics, the ORR is 31.4. Again, this is a durable response, which is very important to us when we think of the significance of a modality. A very new modality that's being looked at as well are so-called bispecific agents. And if you look here on the left hand, you can see what I mean by that. So it's essentially a molecule with 2 different arms, usually one that is hitting a target or binding a target on the tumor cell, and the other that is binding a target on the immune cell. And tebentafusp is the first to have been approved by the FDA for treatment of advanced uveal melanoma in patients who have the right immune subtype. And what I mean by that is HLA-A*02:01, which is about half of patients. And I think this is meaningful, first of all, because the class of drug itself has been around a long time and it's using a lot of hematologic malignancy, but we're starting to see it come more and more to the forefront in solid tumors. And tebentafusp was associated with 20% overall survival in patients treated with it compared to the control arm. There are various bispecifics being evaluated at our institution. This charge is being led by Dr. Devar, including a PRAME protocol that has so far shown us nice preliminary data, but with more mature readouts pending. So this is definitely another space to watch in IO refractory melanoma. And tebentafusp, which is approved in uveal, is actually being evaluated in an ongoing clinical trial in combination with immunotherapy in patients with skin melanoma who have progressed on standard treatments. So where do we go from here? I hope I've given you a flavor of the different classes of drugs and modalities that are being investigated for patients whose melanoma has not responded. Very happily, half of patients never even need to think about this if they're treated with dual checkpoint blockade, ipilimumab and nivolumab up front, but not every patient gets that modality, and even of those that do, half go on to progress. So in addition to the different classes we discussed, a very, very important topic we spend a lot of time thinking about are different biomarkers. Think of a biomarker as something that can give you a hint of what's going to happen. So a predictive biomarker will tell you it can help you predict essentially whether or not a patient is going to respond to treatment. It would be wonderful to have a predictive biomarker to identify who's going to have toxicity, so we know who to treat with what. And so on, and which patients need more intense therapy, which patients can have de-escalated therapy. So this is a huge topic as well in our world. And you get the sense from everything I've shown you that there's really a million different combinations in theory that you could move forward with, but we need to be really thoughtful about so-called rational combinations. And what I mean by that is sound preclinical scientific rationale for combining agent A with agent B. You can't just throw everything at the wall and hope something sticks. In addition to the obvious issue of resources, the most important thing is there are patients going on these trials. And so we'd better have really good reason to believe that it may work. So thinking about tumor biomarkers has really changed a whole lot over time. And the reason I'm taking a minute to talk about biomarkers is because when we think of the next wave of clinical trials and everything I've shown you now, you could argue all this has happened because of particular biomarkers within the tumor and within the host that we think are of clinical significance. And it's that biomarker that drives us to think, well, let's combine A with B or B with C. And this field is changing so quickly, and I think it's becoming really more focused and more narrow over time. What I mean by that is we're not taking a look at the forest, if you will. We're really starting to look at the trees. So in the past, we used to look at mutations. We used to look at PD-L1, which is just there on the tumor. We used to look at signatures of the tumor as a whole, the simplistic view of a cold tumor versus a hot tumor. But what we're doing increasingly is to look at different neighborhoods, cellular neighborhoods within the tumor microenvironment. We're looking at areas where different immune cells are within the tumor, tertiary lymphoid structures. We're looking at the gut microbiome. We're looking at the whole host, not just the tumor itself. And when we're looking at the tumor itself, we're looking at it very specifically with single cell sequencing of different immune populations, et cetera. And so over time, as we refine all these modalities, our hope, of course, is that the hypotheses that we generate are more specific and more apt to show clinical utility. So the roadmap for the future, as I think about it, really is to go on to develop these rational combinations by first taking a look at the tumor itself. Are there immune cells there? Are there not immune cells there? And going from then to think about what are different effectors or targets that might make sense for this patient based on the phenotype of their particular tumor. Once you look at the tumor itself, you can get a sense of, is the problem that you just don't have enough immune cells there? Is a problem that the immune cells are sequestered to the periphery, unable to penetrate into the tumor, and so on. And so in time, we should be able to fine-tune the choice of agents based on specific targets, specific molecules and genes and cells identified within the tumor microenvironment of each patient. And then when resistance develops, to then do this again, it becomes an iterative process. Take a look again at the tumor itself and decide where to go from there. Now, of course, it's not so black and white, nor is it so simple. Tumor heterogeneity, meaning different regions of the tumor look different, is a huge issue. But again, I'm trying to give you a sense of where the field is moving. And so with that, I hope I've given you a flavor for what's really a big topic. I'm so sorry I couldn't be there in person due to family commitments. Thank you so much for your attention, and please don't hesitate to email me if you have any questions at all.